Welcome to this module of treatment of drug sensitive pulmonary tuberculosis. I am Dr. Sridhar, Professor of Thoracic Medicine, Government Stanley Medical College and Superintendent, Government Hospital of Thoracic Medicine, Thombaram Sanatorium. Let us see what are the goals of TB treatment we are aiming at. We want to cure the patient who are affected by pulmonary tuberculosis. We want to prevent death among patients affected with pulmonary tuberculosis. We want to render patients non-infectious to break the chain of transmission which happens within the society and decrease the pool of infection within the society. To minimize and prevent development of drug resistance and to restore quality of life and productivity. And as far as the TB treatment goes, the currently recommended treatment regimens are the results of numerous clinical trials which has been conducted in many parts of the world. And many of the principles of TB treatment were evolved from research at NIRT Chennai, proving the efficacy of domiciliary treatment, proving the efficacy of short course chemotherapy, proving the efficacy of intermittent treatment and proving the efficacy of DOTS, where in which the treatment was administered under supervision. And as far as length of treatment is concerned, TB bacilli are killed during the first 8 weeks of treatment when we are administering bactericidal drugs as a combination with 3 or 4 drugs, and some survive longer and are then killed with continuation treatment which happens after the end of intensive phase. Length of treatment is a critical issue. If administered for too short a time, treatment failure and relapses can occur. We have to find out what is the ideal dosing schedule also. TB patients receive daily treatment. 3 times weekly dosing is not currently recommended by the WHO, either in the intensive phase or in the continuation phase as per the latest recommendation which was published in 2017 May. Let us see the case definitions in TB. The terminology presumptive TB is used now, which was used earlier as suspect TB. These presumptive TB patients who are identified are subjected to either smear microscopy or sputum culture, or sputum is subjected for rapid molecular tests through which we identify and confirm a cases as confirmed tuberculosis case. Sometimes the smear may be negative, radiologically or by other clinical means we may consider a patient as clinically diagnosed tuberculosis case. Anatomical site wise they may labeled as a case of either pulmonary TB or extrapulmonary TB, and based on the history of previous treatment, if there is no previous treatment history, then the patient will be labeled as a case of new pulmonary case or extrapulmonary case. If there has been a previous treatment history, this TB has happened after the previous treatment, that will be labeled as a case of recurrent TB, and if the patient was lost during treatment, he will be considered as a case of lost to follow up, and those patients who failed with their earlier regimen will be labeled as a case of treatment after failure, and some of the patients may belong to other groups. Then some of the patients may be diagnosed elsewhere and transferred to our facility for treatment, they will be labeled as a case of transfer in. As far as drug resistance is concerned, if there is resistance to only one drug except rifampicin, this group will be labeled as mono drug resistance. If they have resistance to only rifampicin or rifampicin resistance is identified by molecular diagnostic, that will be labeled as a case of RR or rifampicin resistance. When there is resistance to more drugs except a combination of INH and rifampicin, they will be labeled as a case of polydrug resistance. If there is resistance to INH and rifampicin with or without drug resistance to other drugs, they will be labeled as a case of MDR TB. And when they have extensive drug resistance, that is resistance to most of the drugs which are available, they will be labeled as a case of extensively drug resistant tuberculosis. Let us discuss the case definitions what we use in tuberculosis. A patient will be labeled as a case of new patient if they have never taken treatment for tuberculosis or if they have taken treatment for less than 4 weeks. A patient who had previous treatment received more than 1 month of treatment will be labeled as a case of previously treated patient. Drug sensitive TB is labeled when the patient's CB nat says that he is sensitive to rifampicin or is line probe assay says is sensitive to INH and rifampicin. What are the drug regimens currently recommended for drug sensitive tuberculosis, both pulmonary and extrapulmonary? For all new patients who never had treatment or had treatment less than 4 weeks, those patients who had previous treatment presenting again with tuberculosis disease, which is confirmed either bacteriologically or by other means, at the same time is still drug susceptible, they will have 6 months of total duration of treatment with 2 months of intensive phase with a continuation phase of 4 months. We will have 4 drugs administered during the intensive phase. R stands for rifampicin, INH stands for H stands for INH, E stands for ethambutol and Z stands for pyrazinamide, which is administered for 2 months, followed by INH, rifampicin and ethambutol for a further period of 4 months. The RNTCP is now recommending daily regimen for treatment of drug sensitive TB in the entire country with fixed dose combinations in appropriate weight bands. Intensive phase is 8 weeks and continuation phase is 16 weeks. No extension of intensive phase is recommended in this schedule. Current 8-month treatment regimen for previously treated TB category 2 should no longer be used. Previously treated TB patients will also be initiated on 2 EHRZ followed by 4 HRE as for new patients. DST should be done at least for INH and rifampicin. Results should not be awaited for starting treatment. If no resistance is detected, treatment is continued. If isoniazid or rifampicin resistance is present, treatment will be decided as per PMDT guidelines. Patients for whom an appropriate specimen is not available for DST should also be started on 2 EHRZ followed by 4 HRE and followed up clinically, radiologically or microbiologically for signs of non-response. The categorization of previously treated TB patients will continue with subcategories like relapse, failure, treatment after lost follow-up, other previously treated, etc. Follow-up for patient care and monitoring treatment outcome will be same as for new patients started on 2 EHRZ followed by 4 HRE. Recording and reporting formats are same as before. Now we will see the dosage of anti-TB drugs which are used in the fixed dose combinations. In the intensive phase, each pill will have 75 mg of INH, 150 mg of rifampicin, 400 mg of pyrazinamide and 275 mg of ethambutol. If the person is weighing between 25 to 39 kg, they will receive 2 pills, and continuation phase will have the pill with INH 75, rifampicin 150 and ethambutol 275. Once again they will receive 2 pills in that. Whereas, if the person's weight band is 40 to 54 kg, the intensive phase and continuation phase will have 3 pills each. If the patient is in the weight band of 55 to 69 kg, in the intensive phase they will receive 4 pills and continuation phase will have 4 pills. Whereas, if the weight band is more than 70 kgs, then they have to receive 5 pills in the intensive phase and in the continuation phase another 5 pills. These are the fixed dose combination pouches from which the number of pills is administered for the patients. What is the WHO recommendations on all these issues? In patients with drug susceptible pulmonary TB, the 6 months rifampicin based regimen is the treatment of choice. Fixed dose combination is better than separate drug formulations and thrice weekly dosing is not recommended. ART should be given to all patients with HIV infection irrespective of CD4 count, and 6 months regimen is recommended for this group also. In patients who require retreatment, the 8-month retreatment regimen is not recommended. It should be decided after DST. Health education, counseling, treatment adherence measures should be provided. And these are the drug dosages which based on which the FDC is formulated. INH at the dosage of 5 mg per kilogram body weight not exceeding 300 mg, rifampicin 10 mg per kilogram body weight not exceeding 600 mg, pyrazinamide administered at the dose of 25 mg per kilogram body weight, ethambutol 15 mg per kilogram body weight. And let us see the definitions of treatment outcomes. We label a person as cured when microbiologically confirmed tuberculosis patients at the beginning of treatment whose smear or culture is negative at the end of treatment completion will be labeled as a case of cured. Whereas, a tuberculosis patient who have completed treatment, at the end of treatment we do not have the data, microbiological data or otherwise, but completed the entire duration of treatment will be labeled as treatment completed. Both the groups put together will be labeled as treatment success as far as treatment outcome is concerned. The tuberculosis patient whose biological specimen is positive by smear or culture at the end of treatment will be labeled as a case of treatment failure. If any patient dies during treatment, that outcome will be labeled as death. If the tuberculosis patients whose treatment was interrupted for one consecutive month or more will be labeled as a case of loss to follow up, and that if by any chance due to drug susceptibility testing showing resistance the treatment regimen is changed, that will be captured as treatment regimen changed. The common drug adverse events which we encounter includes the pill burden, gastrointestinal symptoms, arthralgia, hepatitis, itching, hypersensitivity, rarely renal failure, thrombocytopenia and flu syndrome, etc. When we see the drug related adverse events, all TB patients on treatment should be monitored for adverse drug reactions both clinically and with investigations. Patients should be informed that the urine will be colored due to TB drugs and this should not be a cause for alarm. Most of the adverse effects are likely to be mild and can be managed with symptomatic drugs and with counseling. All tuberculosis patients on treatment should be monitored for adverse drug reactions. What are the treatment support programs that is envisaged? Adherence to treatment is the key to relapse free cure. The counseling of patients and family members will ensure regular treatment. The patient's family, especially children, should be screened for tuberculosis, and initial and frequent follow up counseling of patients and family members is a must. Patients should ideally have nutritional support. There should be a mechanism to retrieve the patients who are lost to follow up, and there should be a systematic screening of adverse events. Psychosocial support should also be available, and there should be a provision for comorbidity management like diabetes and so on. The alternative treatment concept also has to be kept in mind. The principle of patient centric approach, community and family centered dots should be given priority. The information communication technologies, modalities like frequent calls, SMS reminders, apps and IVRS etc. will help us to keep the patients continue with the treatment. Compensation to mitigate out of pocket expenditure like for transportation or for nutritional support can be considered, and incentive for treatment supporters also can be planned, and capacity building and engaging local community like self-help groups, patient support groups can also be considered. There should be a monthly clinical follow up of these patients who are put on treatment, and laboratory follow up to assess prognosis of the disease and manage comorbidities and toxicities should also follow. Sputum smear microscopy at the end of intensive phase is most important to declare the treatment outcome, and if the sputum is positive at any time during treatment, DST should be done as presumptive DRTB case. Long term follow up includes doing sputum cultures for those patients who have completed treatment at the 6th, 12th, 18th and 24 months after treatment to make sure they do not relapse. The new treatment card systematically records all the details about the patient and the follow up details as well. It captures the TB notification number or NICHI ID. It takes the name, complete address of the individual as well as their Aadhaar number. This will affect the patients to have direct benefit transfer of the support from the government, and name of the contact person also is recorded, and the name of treatment supporter also is recorded, and the mobile number is also captured, and the disease classification goes like this: either it is labeled as pulmonary or extrapulmonary, and the type of patient finds as either new or recurrent or transfer in or treatment after failure or treatment after loss to follow up and others also. The basis of diagnosis also is captured either as microbiologically confirmed or clinical tuberculosis, and all the basic data with regard to microbiological diagnosis, pre-treatment, end of IP and end of treatment also is captured with the lab which and lab number, test result, whether it is sent with culture DST and what is the DST result also is captured. Patient's HIV status is recorded, whether the patient received cotrimoxazole preventive therapy also is recorded, when the patient was initiated on ART that is also recorded, if there is a comorbidity like diabetes that is also captured, and children who are having contact with this patient who is sputum positive also is recorded. Children with less than 6 years and more than 6 years are systematically recorded, and INH prophylaxis therapy is initiated for them. Addiction related information is also recorded like current tobacco use or whether there is current alcohol use, and counseling is done for these patients to stay away from these addiction habits. The entire treatment schedule takes both the intensive phase as well as the continuation phase. Whether it is a daily regimen, that information is also captured. According to the patient's weight band, the number of pills is recorded, and it is recorded as per the calendar dates in which the treatment is initiated. If the patient is not taking the drugs regularly, the missed doses also, and when they were retrieved, that is that recordment the details is also recovered. And if the patient has any adverse events during the course of anti-TB treatment, that also gets recorded, and patients follow up details at the end of 6 months, 12 months post treatment, 18 months post treatment and 24 months post treatment is also recorded. If there is any remarks, there is a separate column to record that also. Treatment outcome is recorded with the date, and signature of the medical officer also is recorded with the date. If the patient has received any nutritional support, that is separately captured here. So, the key messages are: the goals of TB treatment are to cure the patient, prevent death and drug resistance, and to prevent transmission of infection in the society. Highly effective treatment regimens are available for drug susceptible TB. Treatment duration is for a minimum of 6 to 8 months with multiple drugs. Under the RNTCP, diagnosis and treatment are free of charge. Regular treatment adherence is crucial for cure. Thank you very much.